I have looked at the injury patterns. I have looked at the numbers related to Boston. My experience into all of this with regards to emergency management is really centered around what occurred on 9/11 at the World Trade Center. I was working for the fire department as an EMS medical director at that time. We actually, although I was not involved, our children's hospital recently had a bus accident which brought about 25 children in at one time. The vast majority of them were very stable, were treated and released. There were a couple of patients that went to the operating room. At other sites where I've been the chairperson, the most routine of them are probably bus accidents, which will bring an influx of 30 children into an emergency department at one time. Fortunately, they are walking kinds of patients that just need to be assessed. A mass casualty incident or a disaster type situation or emergency management is not always built around the total number of patients that are brought in. Very often it's related to the amount of resources that they require. We recently had an incident at the hospital where I'm at that involved a suspect Ebola patient who ultimately ruled out, but that requires a tremendous amount of resources in terms of isolating the patient, moving patients who may be in the vicinity of to another part of the emergency department or to another part of the hospital, and then the staff that's required in terms of maintaining the safety of all the other staff members in terms of personal protective equipment, the cleaning that has to occur afterwards. And so even though that is one patient, that is a very labor-intensive process that can last for 8, 10, 12 hours. So what we've learned from Ebola is good general principles of isolation, of personal protective equipment for the staff, recognition of these patients, and so that regardless of the infectious illness, truthfully, our goal is to recognize it at the front door. Unfortunately, that's not what occurred in Texas. Somebody had to be the index hospital where this was going to occur, but try to recognize these people at the front door, try to isolate these folks regardless of the infectious illness. And once we do that, the emergency is over. We can step back, close the door, and be very deliberative about the process. Hurricanes have become, I wouldn't want to use the word routine because we've now had twice we've now had the 100-year storm in the last couple of years. Hurricanes because they disrupt infrastructure. So people obviously, their own property, for the healthcare team, people lose their own property, they have their own personal needs that need to be addressed. At the same time, these people are being forced into work and need to come into work to take care of the patients. That is our mission. So hurricanes are disruptive, but actually all natural type of events, hurricanes, significant snowstorms, anything that really disrupts other infrastructure within the healthcare system. We learned, and we didn't learn it, but we really experienced it after Hurricane Sandy. There was the loss of dialysis centers because of the power being turned off and power grid issues. There was the loss of methadone maintenance centers. So patients who were very reliant upon outpatient resources, outpatient care, getting their medications from the pharmacy, patients who are home on ventilators and require power. Those patients, their regular needs were disrupted, and so their safety net was to come to the hospitals although their needs at that time were acute, those patients actually put a tremendous stress upon the entire healthcare system. We also learned during Hurricane Sandy, when they evacuated large portions of Long Island, New York City, I'm sure the borders of New Jersey, is that the nursing home patients and all of the nursing homes that were evacuated, we needed to create capacity for those patients, and the hospitals became the safety net for those patients. A lot of the nursing homes were out of business for several weeks because of power grid issues. And so it became very difficult to get patients discharged out of the acute care setting, out of the hospitals, into nursing homes or rehab centers where they would otherwise go. And essentially we ran out of beds. We know more. I don't know how we're going to do it very differently the next time because a lot of these things require capacity. And there is not a lot of excess capacity built into the system because that requires funding. The most important things, obviously, besides the basic stuff, flashlights. If you have a person at home who has special needs in terms of oxygen or a ventilator, a some sort of power generator is essential. If you know a storm is coming, or if you have essential medications that you need to keep at home and your prescription is starting to run a little low and you know a storm is coming and that may be disrupted, refill your prescriptions early and maintain an appropriate excess amount of those medications so that if the pharmacy is out of business for a couple of days, you don't run out of your medications. Obviously some extra food and water and very, very basic stuff. It doesn't have to be fancy, but I think a power generator for those who have needs that, that require equipment, oxygen and respirators, and maintaining an appropriate amount of medication or excess medication somewhere at home in case other transportation or electrical resources are disrupted. Of course not.
Of course.
Physicians, do as I say, not as I do.
Do you have a generator?
Of course not. I don't have a generator at home. I maintain Tylenol and Motrin at home, regardless of the day of the week. But physicians are not always, we say what we say, but we don't always practice what we preach.